Well, thank you for inviting me. I'm honored to be here. Uh, that's my name, and it's pronounced Anh Nguyen-Huynh. It sounds like Anh is like on and off, and Nguyen-Huynh sound like win-win, so you really can't lose. I'm talking today about the use of cochlear implant for situation of asymmetric hearing loss or single-sided deafness. You may not know this, but I'm actually a Clevelander. I came to America and grew up in the Cleveland West Side. Then I received my medical training and ENT training at Harvard. I then moved west, as most young men do, and did my fellowship at Stanford in surgery for the ear and the skull base. I spent the next 15 years working in the West Coast, gaining experience at various institutions. I now have the opportunity to return to the city of my youth and work at the world famous Cleveland Clinic. So I'm glad to be here. I came back just in time for COVID.
Yes.
I don't want this to be, I just want to make sure I say off the bat, I don't want this to be a lecture, but rather informational session. So I like to be as informal as I can and take your question. I don't have the ability to monitor the chat when I'm talking. So if somebody wants to jump in with the question, please do. Since I come back, my family has really enjoyed all the season that Northeastern Ohio has to offer. So I'm glad to be here. Well, I think many of us in the audience have first-hand knowledge of what a life-changing technology cochlear implant is. But as with many great ideas, the basic concept is very simple. You have an internal device. Do you see my cursor, by the way? Excellent. That receive signals from the outside and then transmit them to the cochlea via a long, thin wire. The external microphone and speech processor is actually the brain of the operation, and that's where the speech is received and converted to the electronic signals that will be transmitted. Initially, this technology reserved only for people with very profound sensory hearing loss in both ears. Why was that, you might wonder? It is because when in its infancy, we were not sure how helpful the technology will be, and we were worried that putting this in the ear will destroy the remaining hearing. So we only do it in cases of deafness.
If I could interrupt just a bit. Whoever just came on with your iPhone, please mute your iPhone because you're causing a lot of noise. Looks like, looks like they're muted. Thank you. Go ahead, doctor.
Thank you. Well, over time, we learned two things. We learned that the technology is working and is very helpful to patients with hearing difficulty. So we would like more to benefit from it, and the criteria became relaxed and expanded. So it is defined as anybody with moderate to profound hearing loss with limited benefits from conventional amplification. And what does that mean? The FDA defined it as a speech recognition of 50% or less in the ears to be implanted, and 60% or less in the opposite ear or in both ears. Most commercial insurance will allow implantation in the ears with less than or equal to 60% speech understanding. Medicare is still stuck with the 40% criteria for the time being. Well, then we realized as we implant more and more people with some hearing, residual hearing, that it is possible to preserve what's left with improved electrode design and surgical technique. For example, here I show a picture of the slim straight electrode from Cochlear that very thin and flexible, and it's possible therefore to insert more smoothly into the cochlea, especially through the round window approach. To the right, we have a comparison of the various ways to get into the cochlea. If you can see those number 1, 2, 3 on this particular figure, you realize that the round window is represented here by the small circle labeled number 1. But historically, we also implant into the cochlea via a cochleostomy, a hole drill in the cochlea that are larger and slightly inferior and anterior to the round window. We eventually transitioned to a more kind of an extended round window approach, was a little lip of the window was open to allow the electrode to be inserted. So by purely using only the round window, you do not have to drill much on the surface, on the side of the cochlea, and this is made possible because the electrodes are now thinner and can be inserted into this space. So when we can preserve hearing, we know we can take advantage of the hearing in the sorry, the size is advancing faster than I expected. Since we can preserve hearing, we can take advantage of the residual hearing in the implanted ear. For example, if a patient has residual hearing in the low frequencies in near normal or normal range, it is possible to use a hybrid cochlear implant. Even if you use a more traditional cochlear implant but with the thinner electrode, it is possible to preserve hearing in the low frequency in the area that's considered beneficial to have some sort of acoustic stimulation. So we now have devices that combine hearing aid and cochlear implant processing in the same housing, which would then allow us to help patients who can have preserved hearing. So you don't have to start out with the hybrid implant. We can use a standard implant and then decide on whether or not the strategy is best to use a combination of acoustic and electronic stimulation in the same ear. Of course, that begs the question of what we should do if we can have the stimulation. I mean, we can preserve the hearing in one ear when we implanted the other ear. That means we take advantage of the better ear. This strategy is called the bimodal hearing, and that involve implanted one ear while the remaining ear is still serviceable with hearing aid. That's a condition that I will discuss today, the asymmetric hearing loss situation. Single-sided deafness is, of course, more extreme situation when one ear is deaf and the other ear has normal hearing. I would like to present a case study as a stimulus for discussion among you. The history of a hearing loss that did not recover despite treatment by her physicians with steroid, intratympanic injection of steroid, even hyperbaric oxygen therapy. Her dizziness subsided, however. She still has great difficulty with the localization of sounds and hearing deteriorate with any kind of background noise. She also suffered from constant right-sided tinnitus. So her hearing tests demonstrate that the right ear, the one with the sudden hearing loss, has had a severe hearing loss and in particular no speech recognition. So even though she still has some amount of pure tone recognition, no amount of speech understanding. Her left ear has a normal to a moderate degree of hearing loss, but it's certainly serviceable with hearing aid and with very excellent, decent speech understanding. So she wouldn't be qualifying for the traditional cochlear implant criteria. Well, so what are the options if we want to talk about traditional options? Well, she can get a bicross hearing aid, which is shown here on the right. And that means she's going to be wearing a hearing aid in her good ear, which can amplify the hearing in that ear. But she also have a second microphone and transmitter on the side that is deaf that would then provide communication with the speakers in the good ear so that her left ear, in this case, can hear both sides equally well without the head shadow effect. This does provide some benefit, such as awareness of sound. Social interaction is improved because she won't ignore people who come to her on the right side. But it doesn't help her very much with localization of sound because she's only have one ear working. And her ability to filter out noise from speech is also impaired. This type of outcome is well documented in many research studies regarding cross-hearing amplification. The alternative to a bicross hearing aid has been a bone anchor implant. And in cases of single-sided deafness such as this, the implant will be put on the right side, the deaf side, and the sound will be transferred across the skull by bone conduction to the left cochlea. It does work, and I have done many of these cases, and patients that get excellent benefit in terms of safety, sound awareness, environmental awareness. But again, there's a limitation to the traditional technology. And that's because they only rely on the good ear and cannot work like two ears. Okay? We are born with two ears for a reason. So in this case, our team evaluated her both audiologically, medically, surgically, and we decided that her best option is actually to have a cochlear implant in her deaf ear with a hearing aid fitted for her remaining ear. This is the exact combination that she received. She received a cochlear nucleus with the straight slim electrode inserted through the round window, as I have described previously. Afterward, she's activated with the Nucleus 7 speech processor and then fitted with the hearing aid, the resound hearing aid on the opposite side. This is a hearing test before and after the surgery. As you can see, the right ear hearing, the sensory hearing part, which is seen here, is preserved compared to before surgery, although it is slightly muffled because of some post-op effusion still. We will expect that to improve. So the early result shows that the device activation, she immediately heard. She described that her hearing was low-pitched but clear and the volume was comfortable. And within a week, she was using the implant 12 hours a day. Thanks to her motivation, she demonstrated very clear benefit at 2 months. So this is a comparison of the test result from before surgery, which is in blue, and after surgery, which is in green. So before surgery, we test the best aided hearing with the hearing aid in the right ear, and then we use the same test after surgery with the cochlear implant. So her ability to recognize standardized words presented without context goes from 16% to 52%. And when she was presented with sentences, she's able to improve from 46% to 89%. Even her hearing noise is improved from 4 to 19% at this stage. We expect then that she will continue to improve in the performance of her hearing in combination of the cochlear implant on one side and hearing aid on the other. Well, her success is not at all unusual. This is fairly typical for us. As a team, we have done 65 cochlear implants for this indication, which is asymmetric hearing loss or single-sided deafness. Our team is preparing this for publication. I don't have all the result analyzed, but the vast majority have significant improvement in speech recognition. And the best patients appear to be those who, like our case patient, had a recent sudden hearing loss.
That was you.
Yeah, one other patient achieved 80% word understanding after only 1 month. One of the tools that we now have available is auditory training with recorded materials that will be streamed directly to the cochlear implant via Bluetooth. So the patient can actually have the a recorder, so like a recorded book or other recorded materials streaming directly to the device so that they can practice with, if they dedicate about an hour a day to this, they can really make great progress. The other benefits that we have noticed is tinnitus suppression. I mentioned at the beginning that our patient has a significant bothersome tinnitus in the deaf ear. And most patients who have received the implant in this situation reported they are only aware of the pre-existing tinnitus only when the cochlear implant is off, and never as bad as it was before. This is not unique to the Cleveland Clinic experience. This is in fact one of the findings that was reported in Europe initially when surgeons there began using cochlear implant in single-sided deafness. They find that the benefits for tinnitus suppression sometimes even are more significant than the improvement in hearing performance. You might have questions about insurance cover in case of, because we are really not following the exact criteria that I presented earlier.
Right.
We found in our experience that most insurance, commercial insurance, will cover this if we appeal and explain the great body of information that has been accumulated on the benefits of a cochlear implant in these situations.
Yeah, you're wrong there.
They approved the use of cochlear implant in single-sided deafness in June 2019, now made it even easier to get insurance coverage. Medicare still does not cover, however. Some Medicare Advantage plans do.
Well, which one do?
Is that a question I heard?
There is a question about the Bluetooth use. Could you say a little bit more about that or explain that? I think there was some confusion.
Oh, okay. What is the confusion?
That was my question. If you would just go back over it more slowly and maybe a little more detail about how we use Bluetooth. I assume that we're talking Nucleus 7 as the...
Correct.
But those of us with Nucleus 6, that's not available yet, right?
I'm not aware of that for Nucleus 6.
You said I'm not aware of that. Yeah, for 6. Yeah. Okay, so you could, you don't have to do it right now, but whenever you want to, if you could go back to Bluetooth and explain it.
Thank you. I'm not I can't really address this in great details because I don't usually work with the auditory retraining. Lindsay, do you have something you can add to this conversation?
Sure. So when we do auditory training and oral rehab following cochlear implant surgeries, when somebody has one cochlear implant or has single-sided deafness, it's a little bit more challenging because your ear that doesn't have hearing loss has more challenges with, or it's more challenging because your better ear picks up all the sound. So we have to find a way that you can practice through the new cochlear implant without the better ear hearing everything. So to do this, we usually stream directly to the processor. So in an N7, which and some of the technologies that have a way to stream directly to the cochlear implant, you can either do work on a tablet, the computer, with a remote microphone to let you practice with just that side that has the cochlear implant. With the N6, we have other ways of connecting, like using, so specifically if you have an N6 and you have a mini mic, you can plug the mini mic into something and practice that way. So I think what Dr. Nguyen-Huynh was referencing is that we have to isolate the ear with the cochlear implant so that only that side is getting the practice, because your better ear already knows how to do that job. So we're kind of taking away the sound there so that you can really practice with the cochlear implant side.
I think they're talking about flute.
Thank you, Lindsay.
Yeah, that's
Does that help, Sandy?
not your thing.
It sure does. And maybe while I'm unmuted, what's going on with Medicare? Why don't they cover it?
You asking a question way above my pay grade. I know that many interested parties have tried to sway, but as I think as of 2020, is that Lindsay? 2020 is they have a statement coming out still clarifying that they will cover only if it's 40% or or less.
Yes, that's still the requirements. The cochlear implant companies themselves are working very hard to get FDA approval, the Food and Drug Administration approval, and we're hoping that there's going to be some change in the Medicare regulations. There's some groups and stuff that I can put in the chat while Dr. Nguyen-Huynh continues, that if you have interest in doing some kind of grassroots advocacy, there's a lot of groups who are fighting really hard to get coverage and for this exact situation. So I'll put some of those groups in the chat that people can look at while Dr. Nguyen-Huynh continues.
I actually don't have more slides. I had some data on meta-analysis and systematic review that I prepared, but I didn't think that it would be particularly interesting to the group. So I would rather take questions and have a little discussions about your concern, your experience, and see also to hear from you how I could be a resource for the community.
Well, thank you. Thank you, Dr. Nguyen-Huynh. How do you pronounce your first name? Anh?
On is like on or off.
On or off? On. Okay, you're on.
Yeah. Yeah, actually, when I used to work with a neurosurgeon at the Stanford,
okay,
yeah, it's very funny because he keeps calling me whenever he wants this bipolar to be turned on.
Yes,
so I got the job of operating the bipolar pedal.
Yeah, you're stuck with that name. Sorry. So, yes, so thank you. You have taken down your slides. And
do you want me to put it back on?
No.
I just thought this way I can see more faces.
Oh, for sure.
When I was sharing the slide, I can't see your faces.
Yes. And first of all, yeah, we're going to keep recording. And Lindsay, do you think I need to use the other slides right now, or just go right into? I don't either. So if
I think just opening it up for questions that people have for Dr. Nguyen-Huynh right now, this looks like a perfect format.
yes, so those of you, if you would like to ask a question, if you would unmute yourself, please keep yourself muted if you are not speaking, and go ahead.
I'm Allison here. I put a question in chat, but I can just say it out loud here. I was just curious, when you talked about the preservation of residual hearing, I was wondering if all or most cochlear surgeries these days preserve residual hearing, and I was wondering when that kind of transition took place from the days when residual hearing was wiped out.
Yes. I think the initial impetus for actually documenting the residual hearing begins with the work done in University of Iowa, where they work with the hybrid implant system. And so there was the criteria for entering that study was for people who have excellent non-normal or near normal hearing, at least in the low and even possibly toward the mid-frequency area. So then during that study, the residual hearing is carefully measured and reported to be excellent initially. There was some loss of residual hearing in follow-up studies from the same group, showing that as time goes by, you do lose some hearing that you preserve initially. And that's when I was at the Oregon Health and Science University, I was a member of a team that studied how we can preserve that hearing using a guinea pig model. So the hypothesis we were working on was that the electrical stimulation may have a role in reducing the viability of the cochlea through something called excitotoxicity. So even though we're making great stride in the design of the electrode to be less traumatic, the surgery to be less traumatic, we still have much to learn about how the use of the implant over time, how the programming of the implant or the signal transmission can be more optimized to help the cochlea survive for longer. So that's still a work in progress. But I think that research really encourage everybody, even in people who are not doing the hybrid implant, to start thinking about recording and checking on the residual hearing. Because before that, nobody does. We just do the implant and then we just assume the hearing is lost, and then we just let the electronic device take over. But when we were shown that it's possible to preserve hearing, now that everybody wants to know if they can do it, even without using a hybrid device. So with the new design that goes is more mid-scalar or more lateral wall hugging rather than hugging the modulus, that's the center of the cochlea where the nerve is housed. There's more effort at trying to preserve hearing, and there are some data to show that these electrodes that are not preformed or not hugging the modulus may have a better success at preserving the residual hearing. And so that play into our choice of electrode these days, and that's part of the discussion we have with every candidate, both among the audiologist and the surgeon, about like, you know, which implant which electrode we would be recommended for this particular case, with an eye toward seeing if we can keep this low frequency hearing, see if we can use this low frequency hearing afterward. So I know that the Cleveland Clinic every year go through a process of review where we would analyze our own rate of hearing preservations and report them for everybody. There's a kind of quality control measure. Is that something that University Hospital also do, Lindsay?
University Hospitals is keeping track of that data to determine hearing preservation at this point.
Yeah. So I think everybody now is gonna do the same, just because we know that if we can save it, then we know how to make use of it. So the audiologists are very excited when they do the post-op audiogram and they see preserved hearing, because they know that they can do something with that to help the patient have better experience. And so we will, as a surgeon, we will continue to strive to get that kind of result for our patient.
May I ask a quick follow-up question, please?
Yes.
I just wondered when that shift sort of took place in the awareness of, you know, the medical community and because from a personal standpoint, I don't remember a conversation quite like that in 2015. So I'm wondering, is it just in the last few years, or?
I would think so. I think some places are more, I guess, pioneering than others, or maybe a little more ahead than others. But at this point, I would say the majority of cochlear implant centers in the countries are keeping track of this, at least internally. If they don't publish it or they don't share it with other, at least they're doing it quietly internally to just measure themselves against the yardstick that are published. The studies, the research studies that are out there. And everybody's thinking of ways to do it. There's creative ideas about use of drug-eluting implant and things like that, where you can just have steroid or growth factors or something like that introduced into the cochlear afterward, in order to see if we can help stimulate the survival of the hair cells, supporting cells, and maintain a good environment so that you can have the cochlea and the inner ear be as healthy as possible in the long run.
Thank you.
I have a question. I have a comment. I've had a cochlear now for 6 years, and I suffered from tinnitus real bad. And that's true. When you're wearing your cochlear, the tinnitus just goes away. But when you take it off, it comes right back. But it definitely makes a difference. So that's pretty much my comment. Yeah.
Thank you for sharing. And that's what we heard time and again from our patient as well. I think that at least in America, the use of cochlear implant specifically for the treatment of tinnitus, I think begins sometimes in 2006, I think. So it's been a while. There's some research done about that at University of Irvine, California, and other centers. So it is now it's quite well accepted as indication. And when the patient has a severe tinnitus, we found that it's easier to get insurance coverage as well when they realize that there is no other effective treatment in cases of severe sensory hearing loss, and the cochlear implant will help both the hearing and the tinnitus.
I think Lindsay, I think we have another question from Allie in chat.
Oh, no. Well, that's okay. I'm glad to ask it, but I wanted to give others a chance to ask questions.
Oh, okay. We've got time. Is there anybody besides Ally that has a question right now? I have a little story to tell. My first implant was in 2008, and then a second one maybe 2015. And we weren't talking about hybrids in 2008. And we did my left ear, and my audiologist at the clinic was giving me my follow-up, my first exam after the healing process. And he was standing outside the door, and I could see his face. And when I responded some way, which said that I had a little teeny bit of hearing, I could see him jumping up and down like this in front of the door. He was so excited that I had this little tiny speck of hearing. So it was really cute. Now, in my second implant, we did a lot of, successfully preserve some hearing. And so like if I'm in the shower on the second implant side, I can hear the water, so it's more for more, I think, like location of sound is improved because I have that bit, but it was really cute. So the timing was perfect for your matching your story.
I'm good. I'm good. I think,
Yeah.
thank you. I think you answered my questions. Thank you.
Well, I can't wait until we can get back to be meeting in person.
Thank you so much for joining us today. And I gather you do surgeries at the clinic.
Yes, I do.
How many cochlear surgeries a year is the clinic doing these days, roughly?
In 2020, we did 108 cochlear implants.
My goodness.
108? Oops. Wow. I'm surprised. Yeah.
Yes, we were surprised too. There was a shutdown period, as you recall, for several months where we could not do any cochlear implant because of the governor's order. And then when it comes to the fall, even when we were allowed to do it again, many patients were hesitant because they did not want to be exposed. They have other medical conditions they worry about. So that takes a while to start getting through our wait list. So we were surprised when we tabulated at the end that actually we did more this year than 2020 than in 2019.
Wow.
I have a question.
Yes, please.
Okay. I had my implant about 2.5 years ago, on one side. The hearing on the other side is very limited, 16%. Oh, by the way, I did have residual hearing after the first implant, but that didn't last. So anyway, now I'm at the stage where I'm thinking about a second implant for this other really bad ear. But I haven't got a great result from the first implant. Often I still need to lip read. The sound is often muffled. So, I would say it's better than it was. So my question is, would a second implant make things much better, or would it just be more of the same?
I see.
Or is it impossible to tell?
Would you, if you could share with us why you picked the first site? Was there a reason to pick that particular site?
You mean the left ear? Okay.
Yeah, the one with the first implant. Yeah.
Yeah. Well, that was actually my better ear, but the
better
problem
ear?
was yeah, it was. Yes, it was a big difficult decision because I could hear music, even though speech was my discrimination was very poor.
Mm-hmm.
They picked that ear, they recommended that ear because of vestibular. The vestibular function on that ear is much better than the vestibular function on the other ear, which was the worse ear. So there was a greater risk of dizziness after the surgery. So we went with that ear. So again, we would still have to have vestibular testing again to see, how bad it is, or if it's worth the risk. I'm not sure at the moment. I'm really not sure. So that was why we picked that other ear.
Yeah, thank you so much for sharing that. I
Okay.
think that illustrates how complex the choice of the ear to be implanted is. It's not, so that's not a decision that's so easy to pick. We also have situation where objective testing would say one ear is worse, and the patient tell us it's the opposite. I'm sure, Lindsay, you run into that situation. And unless the difference in the test is like huge, and might point out to some issue that we need to investigate, I usually go with the patient choice. So even if they pick the ear and the team say, well, the other ear seems to be the worst ear. And that actually raised another good point, that something has changed in the years since we began using cochlear implant. Is that when we have a choice between two ears in the past, we often recommend the better ear, because we think that the better ear going into the implant will be the better ear functioning with the implant. So that's a thing that the doctor usually quite adamant about at the beginning, which is very difficult for the patient because they would need to give up their better ear for the surgery. Nowadays is actually we usually go for the worst ear, and that's precisely because there's all this opportunity to combine the cochlear implant on the worst ear with the hearing aid in the better ear, that we have seen benefits for. And then the other thing is that we realize that cochlear implant works quite well even if you implant the worst ear. And so there's no reason to sacrifice your better ear for the first cochlear implant. When you throw in vestibular concern, though, that becomes a tricky situation. And so, we do have patients with Meniere disease who has already lost vestibular function in one or sometimes even both ears, and those are challenging to manage. And we have patients who have acoustic neuroma identified on one side, and you wonder should you implant the side with the acoustic neuroma or not. That actually is a new direction that we had also doing these days in many centers, is if the acoustic neuroma has already been treated or has shown to be stable, not growing, and is unlikely to require surgery, that we would implant that ear, even with the acoustic neuroma, and sometimes even with the acoustic neuroma inside the cochlea. The surgery could still be done successfully. So that's part of the theme of evolving criteria for the use of the implant. And it also points us to some of the opportunity that we did not have before, because people sometimes worry about implanting the ear without the acoustic neuroma, because that is likely to be the one that the brain is relying on for the balance information. So we don't want to take a chance and make the balance worse. But the one with the acoustic neuroma is likely to be an easy choice as far as the balance is concerned, because the balance is probably damaged already. Right. So it's not going to be significantly, not be a significant loss if there's any further loss to be had in that ear. So that a lot of these considerations are taken into account when we evaluate each candidate. And there's always back and forth discussions about between the surgeons and also between the audiologist and the surgeon about which one is likely to benefit more.
I have a question. What is acoustic neuroma?
That's a benign tumor that comes from the lining of the balance nerve or the vestibular nerve. Its technical name is a vestibular schwannoma. That's a fancy name, but most people know it as acoustic neuroma because the most common symptoms presenting is hearing loss. And it is one of the, things that we always consider when someone presents with asymmetric hearing loss or sudden hearing loss. So we need to investigate with a scan like an MRI to find out if the person may have such a tumor. Sometimes the tumor can be identified incidentally on a scan done for something else. I saw a patient recently that when that happened, that the scan was done for something else, and she found to have a tumor. And in fact, on review of past scans, we saw that the tumor had been there several years ago and was never commented upon because nobody was looking for it. She has perfect hearing. She has, normal perfect hearing in both ears. No auditory symptoms at all. No auditory, no vestibular symptoms.
Thank you. I want to comment on your response to questions is so complete and so easy to understand. And I really appreciate, the way you're handling these questions. I know there's a lot of technical stuff going on back there in your mind, but you're really putting out there so that we can understand.
Oh, thank you. Thank you for saying that. That's actually one of my passions. Is teaching. I used to teach, medical students, residents, and so when I moved away from academic medicine for a while, that's the one thing I missed. And so returning to to go into the clinic is a part of my returning to teaching as well, because now I get to teach residents and audiology externs and PA students, so it's all very satisfying, and I enjoy helping patients understand what's facing them, what their choices are, what are some of the implications of their choices, because I believe there's no one size fits all solution to problems, and when you realize what people care about, you can help them achieve that.
Well, one of the things that amazes me, in addition to the fact that these cochlear implants are miracles made by men and women, that they're just absolutely miraculous, is that the difficulty, like you and Lindsay must have, translating what I'm telling you. I mean, it's like asking somebody how much pain do you have, and I say 5. What's that mean? And what can you hear? What can't you hear? And lucky for us, we're in the computer age where when we do that programming, we have numbers to choose from, and things start to become more clear and more finite, more clarified. But I think that you two are in a profession that's part science and part art, because it's just not all that very really clear. So,
thank you for sharing, Sandy.
Yeah. Any other questions? Good. Okay.
Well,
I'm wondering, is there anything that any of you wanted to talk about that doesn't involve this presentation. I mean, Dr. Nguyen-Huynh can certainly join us, but are there any other extraneous thoughts, ideas that you'd like to put out there before we close?
Is this where you wanted to stop recording so everyone can talk privately, or are you saying
right?
for
Thanks for the
things?
reminder.
Okay. So is moving on to the group time versus specifically questions for Dr. Nguyen-Huynh?